Genital wart, also known as venereal wart or condyloma acuminata, are verrucous growth that affect the skin of the labia majora, perineum, perianal region, and vulva. The lesions may be discrete or coalesce to form cauliflower-like growth. The disease is sexually transmitted. The growth of the wart is favored by vaginal discharge, the use of oral contraceptives, and pregnancy. Human papillomavirus causes structural changes in the epithelial cells of the skin. These abnormal epithelial cells are called coelocytes, and their presence is characteristic of human papillomavirus infection. The coelocytes have large hyperchromatic nuclei and a perinuclear halo. The diagnosis is made by colposcopic studies. The lesions on the vulva are stained by toluidine blue. The abnormal areas of the skin retain the blue dye. These areas are then biopsied for histopathological examination. A young woman presented with lesion on her vulva. The likely diagnosis is condyloma acuminata. Condyloma acuminata shows cauliflower-like mass of tissue on and around the female anogenital region. Condyloma acuminata is an epidermal manifestation of the human papillomavirus. Human papillomavirus is transmitted through contact with infected skin or mucosa. The virus invades the cells of the epidermal basal layer through microabrasions. However, anogenital human papillomavirus infection is almost always occurred through sexual contact. Warts are not required for the transmission but are highly infectious because of their high viral load. Molluscum contagiosum is caused by pox virus. Here we can see shiny, pearly white, umbilicated papules with a characteristic dimple at the center. Verruca vulgaris caused by human papillomavirus type 2 shows firm papules with a rough horny surface. Condyloma lata, which is the characteristic feature of secondary syphilis, is caused by Treponema pallidum. A sexually active woman presents with cauliflower-like lesion on the vulva. The biopsy of the lesion is taken. The most likely causative organism is human papillomavirus. Coelocytes, a characteristic feature of infection with human papillomavirus. Other features that can be seen on histology are perinuclear halo, multinucleation, orangiophilic cytoplasm, acanthosis, and chronic inflammatory infiltrate. Henderson-Patterson bodies are seen in Molluscum contagiosum, which is caused by pox virus. Cowdery bodies are seen in herpes infection. Klebsiella granulomatis causes granuloma inguinale. Here the inclusion body is Donovan bodies. Chlamydia psittaci causes psittacosis. Here the inclusion body is Levinthal coli lily bodies, that is LCL bodies. Chlamydia trachomatis causes trachoma. Here the inclusion body is Halberstetter Provazic bodies. Chlamydia trachomatis causes lymphogranuloma venereum. Here the inclusion body is Miyagawa's granulocorpuscles. Corynebacterium bacterium diphtheria causes diphtheria. Here the inclusion body is Babe's earnest granules. Inclusion body of rabies is Negri bodies. Inclusion bodies of Vaccinia variola smallpox is Guarnieri bodies. Inclusion body of variola smallpox is Passion bodies. Inclusion body of Molluscum contagiosum is Henderson-Patterson body. Inclusion body of foulpox is Bollinger bodies. Inclusion body of poliovirus is acidophilic inclusions. Inclusion body of adenovirus is basophilic inclusion. Inclusion body of yellow fever is Taurus bodies. Inclusion body of herpes virus is Lipschitz inclusions. Inclusion body of measles virus is Warthin-Finkeltli giant cells. Inclusion body of cytomegalovirus is owl eye inclusions. Owl eye inclusions are basophilic, predominantly intranuclear, small granular intracytoplasmic inclusions. Inclusion body of Kala Azar is Leishman-Donovan bodies. Inclusion body of trypanosomiasis is morula cells with IgM deposits. Inclusion body of ovarian cortex is Waltard inclusions. Inclusion body of Parkinsonism and Lewy body dementia is Lewy bodies. Inclusion body of amyotrophic lateral sclerosis is Bunina bodies. Inclusion body of multiple myeloma is Russell bodies. Kohl-Ixner bodies are spherical globules surrounded by granulosa cells in the ovary. Serotypes 16 and 18 are present in the bivalent vaccine against the human papillomavirus. It is called Cervarix. Cervarix is given at 0, 1 and 6 months. Gardasil or Silgard is the quadrivalent vaccine against human papillomavirus. It has serotypes 6, 11, 16, 18 and it is given at 0, 2 and 6 months. Gardasil 9 is the non-valent vaccine against human papillomavirus. It has serotypes 6, 11, 16, 18, 31, 33, 45, 52 and 58. In 2020, it has received an expanded indication which now includes the prevention of oropharyngeal and head and neck cancers. Genital warts are treated by a local application of 25% trichloroacetic acid plus 5% fluorouracil. Treatment of genital warts include the local application of podophyllin 25% in alcohol or podophyllin 20% in tincture benzoin daily for 4 days. Other treatment method is 25% trichloroacetic acid plus 5% fluorouracil daily for 4 days. If these two methods, either any one of this method is failing, the following treatment is given, that is imiquimod cream thrice a week for 4 months, or the other method of treatment is interferon ointment or interferon cream or intralesional interferon injection can be used. If medical treatment fails, then cryosurgery, diathermy or laser removal is done. A sexually active woman who presented with an ulcer over the vulva was diagnosed with primary syphilis. The characteristic feature associated with this is firm, shorty, painless nodes that do not separate. Syphilis is a sexually transmitted infection caused by the motile spirochete Treponema pallidum. In primary syphilis, the classical lesion is chancre, which appears within 9 to 90 days from the first exposure. The macular lesion becomes papular and then ulcerates. The ulcer is painless and firm with a punched out base and rolled edges. If left unattended, this heals within 3 to 9 weeks. It is accompanied by painless inguinal discrete lymphadenopathy. Stages of syphilis include primary syphilis, secondary syphilis, tertiary syphilis, and also latent syphilis. Talking about primary syphilis, here we can see chancre, lymphadenopathy, and also Dory flop sign. First of all, about chancre. Chancre is painless, indurated, usually single. The chancre self heals in 1 to 4 months. Lymphadenopathy in primary syphilis is painless, unilateral or bilateral, shorty and rubbery inguinal nodes. Dory flop sign. As the chancre is too hard to fold, it will flip over once the prepuce is retracted back. This is Dory flop sign. Talking about secondary syphilis, in secondary syphilis, some important features that can be seen is pigmentary plaques, psoriasiform syphilitic lesions, generalized diffuse non-tender lymphadenopathy, moth-eaten non-scarring alopecia, condyloma lata, and also snail track ulcers. What is snail track ulcers? Mucus patches that are flat erosions on the tongue that can coalesce to form snail track ulcers. These are the most infectious lesions. Yet another thing is generalized non-itchy rash with no vesicles present on the palm and sole. This is the most common lesion. Next, about tertiary syphilis. Tertiary syphilis includes gummatous syphilis and also pseudo-chancre redux. So, gummatous syphilis, they are deep punched out ulcers with gum-like secretions on the floor. Pseudo-chancre redux is a gumma occurring at the site of a previously healed ulcer. In tertiary syphilis, CVS and also CNS is affected. Aortitis and aneurysm of the ascending aorta, general paresis of the insane and tabes dorsalis, these all are present in tertiary syphilis. Next, about latent syphilis. It is the period between secondary and tertiary syphilis. In this period, the patient is asymptomatic clinically and only serological evidence of the infection is present. Latent syphilis is classified into early latent syphilis and also late latent syphilis. Early latent syphilis is within 1 year of infection, and late latent syphilis is after 1 year of infection. Condyloma lata is a classical finding of secondary syphilis. Multiple moist, well-demarcated papules and plaques are seen in condyloma lata. They are highly contagious exophytic broad excrescences that ulcerate and are commonly seen on the vulva, perianal area and upper thighs. The causative agent for lymphogranuloma venereum is Chlamydia trachomatis. Serotypes are L1, L2 and L3. Lymphogranuloma venereum is a sexually transmitted disease that causes genital ulcers. It has the following 3 stages of infection: primary stage, secondary stage and late stage. Primary stage of LGV includes painless genital ulcer, papules and lymphangitis. Secondary stage of LGV includes painful unilateral or bilateral lymphadenopathy, buboes and groove sign. Late stage of lymphogranuloma venereum includes stricture formation, fibrosis and fistulae of the anogenital region. Chlamydia trachomatis is a small gram-negative bacterium and an obligate intracellular parasite that appears as an intracytoplasmic inclusion body. The gram stain of the cervical smear would show leukocytes but no organisms. Hence, selective culture media like the McCoy cell culture is used to isolate the organism. Iodine-stained smear prepared from the patient's endocervical sample is used here. It shows inclusion bodies characteristic of Chlamydia trachomatis. A 26-year-old sexually active man comes to a STD clinic with painful genital ulcer. On examination, the ulcer and right inguinal lymph nodes were tender. The causative organism is Haemophilus ducreyi. Haemophilus ducreyi is a gram-negative anaerobe. Chancroid is symptomatic in men. Both ulcer and lymphadenopathy are painful. Lymphadenopathy in chancroid is either unilateral or bilateral. Chancroid is generally asymptomatic in women but sometimes presents as painful lymphadenopathy. Chancroid ulcer shows purulent and also hemorrhagic discharge. It has a non-indurated erythematous base. Important features about genital herpes. Incubation period is 2 to 7 days. Organism is herpes simplex virus 2 more than herpes simplex virus 1. Cluster of vesicles on erythematous base present. Painful and pruritic lymphadenopathy present. Zang preparation shows multinucleated giant cells. PCR should be done. Treatment of choice is acyclovir or famciclovir or valacyclovir. Next, about syphilitic chancre or hard chancre. Incubation period is 9 to 90 days. Average is 21 days. Organism is Treponema pallidum. Here, single painless ulcer with a clean base and a firm raised border can be seen. Painless lymphadenopathy present. Clinically, we should diagnose this condition. Treatment of choice is penicillin or ceftriaxone. Next, about donovanosis or granuloma inguinale. Incubation period is 1 to 12 weeks. Organism is Klebsiella granulomatis. Painless papule or nodule erodes into beefy red granulomatous ulcer with rolled edges. No lymphadenopathy present. Pseudobuboes are seen. Donovan bodies are seen on biopsy. Treatment of choice is azithromycin or doxycycline. Next is chancroid or soft chancre. Incubation period is 1 to 14 days. Organism is Haemophilus ducreyi. Painful ulcer can be seen. Painful inguinal lymphadenopathy present. It is diagnosed clinically. Treatment of choice is azithromycin or ceftriaxone. Lymphogranuloma venereum. Incubation period is 3 days to 6 weeks. Organism is Chlamydia trachomatis serovas L1, L2, L3. Painless genital ulcer present. Painful inguinal lymphadenopathy present. Diagnosis is by nucleic acid amplification test. Treatment of choice is doxycycline. A sexually active man presents with complaints of painful swelling over the inguinal region. He also gives a history of painless genital ulcer that resolved spontaneously. On examination, groove sign is seen. Likely diagnosis is lymphogranuloma venereum. The pathognomic groove sign of Greenblatt is suggestive of lymphogranuloma venereum caused by Chlamydia trachomatis, serotypes L1, L2, L3. Groove sign is seen in 1/3 of the cases in the secondary stage of lymphogranuloma venereum. It refers to the depression between the enlarged femoral and inguinal lymph nodes on either side of the inguinal ligament. Lymphogranuloma venereum is a sexually transmitted disease that causes genital ulcers. A 20-year-old female sex worker presents with complaints of constipation and blood in stools for 3 months. On digital rectal evaluation, a circumferential constriction is felt beyond which the finger cannot be advanced. The given clinical scenario is suggestive of rectal stricture, which is a complication of lymphogranuloma venereum. Lymphogranuloma venereum is a sexually transmitted disease caused by Chlamydia trachomatis serotype L1, L2, L3. Rectal involvement is commonly seen in women as the primary disease often goes unnoticed and untreated. Anorectal involvement causes proctocolitis and causes rectal strictures. This occurs due to the contagious spread of the primary infection from the perirectal nodes, leading to scar tissue formation. The complications of lymphogranuloma venereum include proctitis, vulval cancer, rectal stricture formation. Rectal stricture formation may lead to intestinal obstruction and also rectovaginal fistulae. The causative agent for granuloma inguinale or donovanosis is Calamytobacterium granulomatis. It is now called as Klebsiella granulomatis. It is a gram-negative bacillus causing chronic ulcerative infection of the vulva. A 19-year-old girl presented with multiple beefy red ulcers over the labia. Microscopic examination of smear from the lesion showed intracytoplasmic inclusion bodies and gram-negative bacteria having a safety pin appearance. The given clinical scenario is suggestive of granuloma inguinale, which is caused by a gram-negative bacteria Klebsiella granulomatis. Granuloma inguinale begin as a painless nodule that later ulcerates to form multiple beefy red painless ulcers. These ulcers tend to coalesce and bleed easily on contact. If secondarily infected, they may become painful. The ulcers heal by fibrosis, which can result in scarring resembling keloids. The lymph nodes are usually uninvolved but can become enlarged. New lesions can appear along the lymphatic drainage channels. The gross image shows granuloma inguinale of the cervix with a beefy red appearance of the hypervascular intravaginal tissues. The microscopic finding is suggestive of pathognomic intracytoplasmic Donovan bodies, and also we can see clusters of gram-negative bacteria with a bipolar or safety pin appearance. Completely dilated cervix is a prerequisite for forceps delivery. Prerequisites of forceps delivery include experienced operator, engaged head, ruptured membranes, vertex presentation, completely dilated cervix, precisely assessed fetal head position, cephalopelvic disproportion not suspected, absent fetal coagulopathy or bone demineralization disorder. Before operative vaginal delivery, the bladder should be emptied to provide additional pelvic space and minimize bladder trauma. Wrigley's forceps is a type of outlet forceps. Rotation of the fetal head should not exceed 45 degrees for the application of outlet forceps. This is because it increases the risk of vaginal wall lacerations. Criteria for forceps delivery. Criteria of outlet forceps include scalp is visible at the introitus without separating the labia, fetal skull has reached the pelvic floor, fetal head is at or on the perineum, sagittal suture is in AP diameter or right or left occiput anterior or posterior position, rotation does not exceed 45 degrees. Next about the criteria of low forceps. Leading point of fetal skull is at station more than or equal to +2 cm and not on the pelvic floor. rotation is 45 degree or less, or rotation is greater than 45 degrees. Criteria of mid forceps is station of fetal head is between 0 and plus 2 cm. Criteria for high forceps is not included in classification, so it's not used anymore. Forceps can be used for delivery of the aftercoming head of breech. The advantages are as follows. Delivery can be controlled by giving pull directly on the head and force is not transmitted through the neck. Flexion is better maintained. Mucus can be sucked out from the mouth more effectively. Vendos can be used for occipital transverse or posterior position. A 25-year-old woman at 35 weeks of gestation is wheeled into the labor room following the onset of labor. A forceps delivery is planned for her. Forceps can be used to deliver a preterm baby where it is believed to form a protective cage. Vacuum is contraindicated in these cases. Contraindications of forceps delivery include unengaged head, cephalopelvic disproportion, malpresentations like brow and face, that is mendo-posterior position, cervix not completely dilated, inability to define position, fetal coagulopathy or osteogenesis imperfecta. Forceps delivery is only reserved for mendo-anterior position. Commonly used obstetric forceps include Simpson forceps, Elliott forceps, Keelan forceps, Piper forceps, Tucker mainline forceps, Barton forceps and traction handle. Vacuum delivery system is used for vacuum assisted vaginal delivery of the fetus. Theoretical advantage of ventos or vacuum extraction compared to forceps include simpler requirements for positioning of the fetal head, lower maternal trauma rates, avoidance of space occupying blades within the vagina. A 28-year-old G2P1 woman with a history of mitral valve prolapse was planned for ventos delivery. Minor scalp abrasions and subgaleal hematomas in newborn are more frequently seen with ventos delivery than with forceps delivery. Maternal morbidity is seen more with forceps deliveries and perinatal morbidity is seen more with vacuum deliveries. Maternal morbidity seen in operative vaginal deliveries include pelvic floor disorders, postpartum hemorrhage, increased third and fourth degree vaginal lacerations. Perinatal morbidity seen in operative vaginal deliveries include vacuum-assisted perinatal injuries and also forceps-assisted perinatal injuries. Vacuum-assisted perinatal injuries include cephalhematoma, subgaleal hemorrhage, retinal hemorrhage, neonatal jaundice secondary to these hemorrhages, shoulder dystocia, clavicular fracture, intracranial hemorrhage, and scalp lacerations. Forceps assisted perinatal injuries include higher rate of facial nerve injury, brachial plexus injury, depressed skull fracture, and corneal abrasions. In cardiac patients, vaginal delivery is preferred. It is conducted with the laboring woman in an upright or left decubitus position. Prophylactic use of vacuum is done to cut short the second stage of labor. This is to minimize aortocaval compression. Caesarean section is not preferred since it is associated with more blood loss and higher thromboembolic and infection risk. Deep transverse arrest is an indication for vendos delivery. In vendos delivery technique, suction is created within a cup placed on the fetal scalp such that traction on the cup aids fetal expulsion. The important step in vendos extraction is proper cup placement over the flexion point. The vacuum is gradually created by increasing the suction in increments of 0.2 kg per centimeter square every 2 minutes until a total negative pressure of 0.8 kg per centimeter square is reached. Progressive descent should accompany each traction attempt. Therapeutic indication of vendos is fetal distress in second stage, maternal distress in second stage, prolonged second stage, high vacuum for second twin, and also deep transverse arrest and persistent occipito-posterior. Prophylactic indication of vendos is VBAC, cardiac defects, anemia, and also preeclampsia. Contraindication of vendos delivery is preterm head, face presentation, fetal coagulopathy, fetal blood sampling. You are an intern posted in the labor room assisting the delivery of a primi gravida in labor. The obstetrician planned for a Vendo's delivery because of maternal exhaustion. She asked you to place the Vendo's cup. Where will you place it? An important step in vacuum extraction is proper cup placement over the flexion point. It is a point on the sagittal suture that lies 3 cm in front of the posterior fontanelle. Advantages of correct positioning of cup in vacuum extraction is maximum traction, minimum cup detachment, twisting of fetal head is avoided, smallest head diameter is delivered through the pelvic outlet, success rate is improved, fetal scalp injury rates are lowered, perineal trauma is reduced because the smallest fetal head diameter distances the vulva. A 24-year-old term primi gravida was brought to the hospital in labor. Prophylactic Vendos was used due to ineffective expulsive efforts by the mother. The maximum negative pressure used in this procedure is zero point 0.8 kg per centimeter square. Gradual vacuum creation is recommended. This is generated by increasing the suction in increments of 0.2 kg per centimeter square every 2 minutes. This is done until a total negative pressure of 0.8 kg per centimeter square is reached. This low incremental approach would allow for a more firm attachment of the vacuum cup to the fetal head and thereby a lower failure rate. A prophylactic Vendos was planned for an anemic pregnant woman. Delivery through this mode should occur within 3 pulls over 15 to 20 minutes. A 24-year-old primi gravida delivered a full-term male baby by assisted forceps delivery. What is the advantage of forceps over Vendos? No maternal effort is needed. Quick in case of fetal distress. Can be used in face and breech. Can be used in preterm. Less cephalhematoma. Delivery failure is less. What is the advantage of Vendos over forceps? No need of anesthesia, less expertise required, less maternal injuries, promotes auto rotation, does not occupy the sides, less traction force needed. Auto rotation is seen with vacuum extraction and it is not seen with assisted forceps delivery. During a routine checkup of a multigravida at 32 weeks of gestation, the fetus was found to be in breech presentation. The obstetrician planned to do an external cephalic version. The ideal time to do external cephalic version is 37 weeks. This procedure is attempted in a woman who has completed 36 weeks of gestation and has a breech fetal presentation. Before 37 weeks, a breech presentation has a high likelihood of correcting spontaneously. Moreover, if performed too early, there is time to return back to breech. After 37 weeks, the success rate of external cephalic version are very low. Although it can be performed until the early stage of labor, it is not recommended. A 25-year-old multigravida at 36 weeks presents for routine antenatal checkup. On examination, a hard ballotable structure is felt at the fundus. Non-stress test is reactive. The obstetrician performs the following procedure, that is external cephalic version. The relative contraindication for this procedure, that is external cephalic version, is intrauterine growth restriction. External cephalic version is done to bring the favorable cephalic pole in the lower pole of the uterus. Indication of external cephalic version is breech presentation and transverse lie. Contraindication of external cephalic version include obstetric complications like severe preeclampsia, obesity, elderly primi gravida, bad obstetric history. Others are Rh alloimmunization, multiple pregnancy, ruptured membrane, congenital malformation of uterus, abnormal CTG, contracted pelvis, fetal causes like hyperextension of the neck, that is stargazing position, or large fetus, that is more than 3.5 kg, congenital abnormalities, dead fetus, fetal compromise, and also APH due to risk of placental separation. These all are the contraindications of external cephalic version. Mediolateral episiotomy is directed at an angle of 60 degrees. The mediolateral episiotomy incision starts in the midline at the fourchette and is directed at an angle 60 degree from the midline. This 60 degree angle takes into consideration a distortion of perineal anatomy during crowning and ultimately yields an incision that is 45 degree from the midline following delivery. Mediolateral episiotomy begins within 3 mm of the midline in the posterior fourchette and is directed laterally at an angle of at least 60 degrees from the midline. This yields an incision of 45 degree of the midline. It is essentially an inflicted second degree perineal tear. Structures cut in mediolateral episiotomy are posterior vaginal wall, superficial and deep transverse perineal muscle, bulbospongiosus and part of levator ani, fascia covering those muscles, transverse perineal branch of pudendal vessels and nerves, subcutaneous tissue and skin. Advantage of mediolateral episiotomy is lesser risk of anal sphincter laceration, hence it is preferred over median episiotomy. Disadvantage of mediolateral episiotomy is increased blood loss and causes more perineal pain and dyspareunia.